All right, so no financial disclosures. Can we have a land acknowledgement? Oh, I guess the meeting's automatically transcribed. It's so interesting. Okay, so where we are on the roadmap is today, we're really going to review cases. I think there was a lot of interest in that, and then troubleshooting some of the experiences that you've had. Grant did send me a little snippet about an overview of the cases that you guys had logged. And so I wanted to first say congratulations for stemming or stopping kind of fake news about needing or requiring folks stop their full agonist opioids in order to start a butrans patch. And then I also noticed that there were a couple symptoms that had come up and wanted to check in to see how that went. You know, and my experience and experience of some of my colleagues here that we were actually just talking about last week with the butrans patch, especially for folks who are opioid naive, in which you can start the 5 microgram per hour patch. It seems that nausea is not totally uncommon in the first like 3 to 4 days. And so a lot of times my colleague will just preemptively tell somebody to take some antiemetic, like Zofran or something, for that first part of the week until the Bupe gets to steady state. And we're not really quite sure what it's from. You know, we were thinking that maybe it's just due to exposure to an opioid, similarly to how many folks have nausea when they're starting opioids for the first time. And in the same kind of way as their body becomes more used to it, it dissipates. These are some of the questions I know that Grant and Sandy had been collecting from everyone. And so just to let you know that I'm aware of the questions and we'll get through it, if not today, but before the end of the entire series. But a couple of easy questions just to point out in case other people, or you are wondering if other people were thinking the same thing. So there's a question about transitioning off buprenorphine or what happens if a patient goes to hospice. We'll talk a little bit about that and whether hospices and the folks in hospice are comfortable managing buprenorphine. What would you do with something like that? There's a question about how appropriate it is to use buprenorphine as a tool to help somebody wean off opioids together. And that's a great question because that's definitely one of the uses for buprenorphine. There's a quick question about which Bupe products you can cut. So you can basically cut the films, the tablets, the buccal films. You just can't cut the transdermal patches. Just think of like fentanyl patches. And with this one patient, I really wanted to cut it, but the pharmacist is no, because I think they have to say that. But without knowing which sort of patch matrix your patient is going to have, the formal recommendation is really just not cutting the butrans patches, the same way that you really are never advised to cut the fentanyl patch. So everything else you can cut or split. And then there were several requests to go through cases with low dose initiation, especially thinking through some of the tricky decision points. So what to do with the other full agonist opioids, when to stop the long acting, et cetera. And we'll go through that today. And then other recs for managing precipitated withdrawal and the use of IV buprenorphine, which we'll probably save until the next time. Unless you guys are actively using it inpatient. No, not yet. Okay. So about the question with hospices, in general, hospices are not comfortable managing buprenorphine, and buprenorphine's not part of their traditional formulary, although there are more hospices who are learning about it and actively creating educational curricula around it. This is one paper that came out like within the last year that surveyed 175 hospice clinicians of many disciplines. So there are physicians, nurses, nurse practitioners, et cetera. And there was a high rate of caring for patients with opioid use disorder or another substance use disorder in the hospice, so about 60%. And while 62% felt that it is their role to treat patients with concurrent SED while they're in hospice, 56% reported lack of comfort using buprenorphine as OUD treatment. And when asked about pain, 45% of respondents were not comfortable managing pain for patients on buprenorphine. And contrast this to like 73% who felt comfortable managing pain for patients who are on methadone, which is something that we're more familiar with overall in the pain world and the palliative care world. So my takeaway from this is that often when I have a patient who's transitioning to hospice, I'll try to just chat with either the medical director or the nurse who's taking them over to see how comfortable their hospice is with buprenorphine. And I'll give them a couple of guidance recommendations based on how the patient's been doing with me. So if the patient's pretty stable on the buprenorphine, I will let them know, like, I would continue this, if the pain gets worse, maybe first try this, like first try increasing the full agonist opioid. Or if it gets, much worse than that, then maybe come down on the dose of the buprenorphine, or I'll just give them a couple of contingency planning recommendations, just so that the patient isn't necessarily rotated off the buprenorphine right away if there's no reason to do that. If my patient is like admitted in the hospital and we've been working on pain and I know they're transitioning to hospice or even in the outpatient setting and the pain is already a little bit tenuous for me to manage with the buprenorphine, in that case, I might just preemptively transition that patient to a full agonist opioid and ensure that that transition goes smoothly and that the patient is at the right dose before handing them off to hospice. So it depends a little bit what your assessment is of the clinical situation. And I think knowing beforehand that hospices don't have the most familiarity with buprenorphine, like pre-planning for that. And then some hospices will tell me that they just don't have Bupe on formulary. So in those cases, I will rotate the patient off and stabilize them before they transition as much as I can. Does that answer that question? Or feel free to add to the chat if there are additional pieces of that. Oh, skip that. So the question about whether buprenorphine can be used for opioid tapering. So absolutely, buprenorphine can be a useful taper that is safer than a full agonist opioid. And so during that bridging time, your patient is going to have, safer exposure to opioids. And for some people who have this complex, persistent opioid dependence, you can use buprenorphine either as maintenance treatment or as, again, the bridge while they're on a prolonged taper. So complex, persistent opioid dependence, as you may know, is really when somebody has a flare-up of physical, mental symptoms as they are coming down on opioids, right? So it's somebody who maybe was doing stably on opioids and has indications to try a taper, as almost everyone does. And during the taper, when you reduce the full agonist opioid, they might actually get more dysfunctional. So worse sleep, more pain, which is to be expected, but worse function. Like I had a patient who stopped going to work because they felt such low energy and kind of depressed with kind of the appropriate tapering dose. So like 10% every month. So it was very small, but it triggered all of these symptoms. And so for that patient, who really couldn't tolerate the taper is kind of the stress test to elicit how dependent they were on opioids. And it's not a simple physical dependence, right? So it wasn't just like maybe they had some nausea and insomnia and worse pain, but they also felt depressed. They felt really low energy, like listless, and kind of angry. So that then became this more complicated opioid dependence. Some people think that it's similar to a mild opioid use disorder, but the semantics don't really matter. It's just that they're in this gray area where you can't taper them off kind of cleanly the way that the algorithms would suggest. So for that patient, we switched them over to buprenorphine and kept them maintained there and then continued to try tapering in a prolonged timeline off the buprenorphine. So there's this algorithm here that was published in JAMA for tapering, and you'll see, it starts at the top with like assess benefits and risks of continuing opioids at the current dose. If risks outweigh benefits, then it brings you down this taper profile or taper algorithm. And if the patient is unable to taper down until the benefits outweigh the risks and either meets criteria for opioid use disorder, in which you could start buprenorphine as office-based treatment, or whether they don't meet criteria for opioid use disorder, you could still transition them to buprenorphine and do a slow taper there. So the answer is yes, you can definitely rotate someone over. And that's what we find ourselves doing or starting to really try to do with a lot of patients in survivorship, right? So whether they taper off from their full agonist opioid, or whether it's a little tricky and they feel like they need opiates for a prolonged time, then we'll switch them over to buprenorphine and let them stabilize and continue to work on the taper that way.
It seems like, Janet, like one of the principles, whether you're using buprenorphine to treat pain and like maintain someone, or to like use buprenorphine to ultimately get them to taper down, at some point you're trying to use buprenorphine to meet them where they are, wherever that is. And you're either continuing that or you're kind of doing a slow taper. And it's kind of that low dose initiation that's like the meeting where the patient is. That's probably, I imagine, very similar, regardless of what you're going to do after you sort of meet them where they are. Is that a good way to think about it?
Right. That's exactly right. Yeah, you're going to meet them where they are and just switch them over from whatever they're on to buprenorphine, and then decide and then stabilize. And then from there, you can decide, as you always are with patients, like, should we continue or should we try to taper? It doesn't go well if you are trying to rotate someone to buprenorphine and then you undershoot it, as in like this can be part of the taper. You just want to rotate and stabilize first, and then decide from there what to do.
And it sounds like maybe one of the differences would be if your ultimate goal is to taper, you might try to taper the full agonist opioids first, just to see how low they can get, which would be very different than what we're calling like a low dose initiation, where you're just trying to convert where someone is with their other OME use to buprenorphine, anticipating you're going to like maintain them for their pain management.
Yeah, that's a different way of looking at it too. I think about it as, however the patient is stabilized on their full agonist opioid, whether it's maintaining their current dose or whether they're in the taper with you, like from that point, wherever it is, after you've tried to taper or after they've titrated up to get to this point, then taking from wherever they are, as you were saying, Grant, and switching over to buprenorphine with low dose initiation is the next step. So definitely, if somebody's agreeable to taper, I would try to taper them off their full agonist first. And I wouldn't necessarily rotate them to buprenorphine to taper, just because that complicates an already complicated process. If in the trial of the taper, they've demonstrated that it's harder than expected, or that they will most likely end up on opioids for a prolonged taper, like over months perhaps, then in that case, I would think about, okay, well, buprenorphine might be the safer alternative for you during all of these months while you're tapering. And certainly if you're tapering someone down and then they reach this point where they just really can't get off that final, like 10 milligrams of oxycodone, like 3 or 4 times a day or 3 times a day, then you can decide like, well, maybe this works for you. Or at that point, this might be a patient who's going to be on opioid therapy for longer term. And so that might be a point to think about switching over to buprenorphine as well, whether you maintain them on that low dose or whether you still continue to try to taper slowly. So just to review a little, and I want to go into this, and I don't want to belabor the point, but just to make sure that we've covered all of the steps with the low dose initiation, since I know that's the next frontier for folks, and that there are a lot of questions asking about the steps. We're going to go through in detail. So column 1 is the day, column 2 is buprenorphine transition option 1, and column 2 is the blue is a different option. And then column, I guess technically 4 is what to do with the full agonist. So the points that I kind of focus on in thinking about coming up with a low dose initiation regimen are day one, what the starting dose is of buprenorphine. So in this yellow option, you have the 20 microgram per hour patch. In this blue option, if the patch is not available to the patient, the equivalent starting dose is roughly 0.5 milligrams of the sublingual buprenorphine. That's whether it's film or tablet. one time. Usually I'll recommend, as you all know, the yellow column. So using the transdermal as this initiation, just because it's a little bit more simple, I think, through the patch mechanism itself. It's naturally going to be a low dose initiation with a slow absorption and a slow titration up for bioavailability. So then once the patch is on, it takes 3 to 4 days to reach steady state, as you know. I'll give it a day and then start to go up on the sublingual buprenorphine doses. And this part, there's no, you'll see, I'll give you a couple examples of published protocols and we'll work through some, but there's no set way to increase the sublingual buprenorphine, which makes it easier and harder, right? So you have a lot of flexibility depending on how your patient's feeling, depending on the clinical situation, and depending on how you're feeling. So you might see some protocols titrate this up a little bit more aggressively. I tend to be, especially in the palliative care setting, a little bit more conservative. Like I might go up by 1 milligram at a step up, or 2 milligrams by a step up, instead of going up by a full 4 milligrams. So then the second point when you are putting together a regimen is thinking about what to do with the full agonist opioid. And before you try to put a regimen down, you should have already decided kind of clinically what the appropriate thing is to do with that full agonist. Like, what's your ultimate hope for that? Are you hoping that the patient are you hoping to stop prescribing full agonist opioids? You know, is this a patient where you don't think that that's appropriate? Or is this a patient where you're like, okay, I'm okay with you having some PRN breakthrough full agonist opioid at home? And then that'll really dictate where you end up with the full agonist opioid here on the bottom. So remember, throughout the low dose initiation, you want to continue the baseline full agonist dose until the buprenorphine reaches some critical threshold where when you start dropping the full agonist, the bupe has enough strength in it to keep the patient out of withdrawal. And this would not be precipitated withdrawal. This would be withdrawal due to an overall reduction in the total opioid load that the patient has. So for patients who have a low tolerance, and I'm thinking low tolerance in terms of like patients who have pain and not necessarily, and no OUD, you can start thinking about tapering off the full agonist opioid somewhere around 6 to 8 milligrams of buprenorphine sublingual and give that a try, or you could keep it going. But for, if you wanted to move it up, like I'd say that's that critical mass threshold, having 6 to 8 milligrams of sublingual bupe on board, where if you were to start reducing the full agonist opioid, the patient is not going to feel that drop in opioid effect. If you have a patient with a high tolerance, so somebody with OUD, say when we rotate somebody or start someone on buprenorphine for the addiction medicine service, we really try to get bupe to a critical dose of like 16 milligrams before we switch up the full agonist opioid. And that's oftentimes because the patient is on oxycodone 20 to 30 milligrams Q3 hours around the clock, or some tolerance like that in treating OUD. And so at 16 milligrams, then we can reduce the full agonist opioid and stop the buprenorphine. In general, the approach here is to take the person off the long-acting full agonist first. So switch over the long-acting to the buprenorphine, and then decide what to do about the short-acting. Is this person probably going to continue to have little flares of pain where they might need that? Then you can keep it going. If their pain is pretty stable or opioids aren't proving to help improve function, then maybe take it off. If it's a person where I'm concerned that they are selling or sharing their medications or not using everything that I'm giving, or I can't really tell what's going on, then my goal might be to reduce the short acting as low as it can go until they tell me that there's some flares of pain. If it's somebody who is selling or sharing their meds, then I might decide, like, I'm not going to prescribe any short acting for you because that doesn't show up on your urine tox. So then the third place to look at when you're crafting your regimen is, where do you stop titrating the bupe? And so for patients with OUD, this is a little easier because we're aiming for the known effective treatment dose, which is 24 milligrams of sublingual a day, or 16 at a minimum, sometimes a little bit more, 32. So if you have a patient with OUD, I'm like, keep titrating the buprenorphine until you get to at least 16, if not 24. if you have a patient with pain, the effective dose can be much lower. Like if you have a patient with just pain and no OUD, it can be lower. It's oftentimes in the single digits. I'd say usually somewhere around 6 to 12 milligrams of sublingual buprenorphine is where I would start to really assess, like, how is the pain? How is your function? How are you feeling? And then at any point between that 6 to 12, it could be a step off point. Like, okay, this is your dose. So it's a little easier with OUD because we have a known treatment dose. It's harder with pain only because that really depends on your patient. And I'll show you one study here and kind of where they ended up with pain. So let's try a case. And so we have a 55-year-old woman, breast cancer, now no evidence of disease, pretty long prognosis. She's taking oxy, extended release, 80 milligrams 3 times a day. That's it, no other short acting. Agreeable to starting buprenorphine. What would you propose for this rotation? And it says, what's your goal with the short acting? There's no short acting here. So you could decide to offer her some short acting if that's what you think is appropriate for her situation. Let me give you this table. If you're not driving and otherwise like, okay, with scribbling some things down, like let's work through this together. So I want you to create these columns, right? So first column is the day. It doesn't have to go 1, 2, 3, 4. It could go like 1, 7, 14, whatever you think. The next column is the bupe. So what is the buprenorphine regimen that you would propose for that day? And then the third just helps keep track of the total daily dose. That's the TDD of buprenorphine. So if you have someone on 1 milligram BID, that's a total daily dose of 2 milligrams of sublingual. And then the third is long acting, and the fourth is the short acting full agonist opioid. So I'm just going to give you a minute to jot down what you would propose doing for this patient who is on OxyContin or oxycodone long acting 80 milligrams 3 times a day. How do you get that patient onto buprenorphine? And since you don't know where to stop, I would just keep going. Like you would, go until like, say they're at least you have a plan to get them to bupe 12 milligrams total a day. So since I know you've been thinking about this, Grant, do you mind starting us off in going through what you would think or what you might propose?
Oh yeah, happy to start. I feel like that's the easier part. So I would start a 20 microgram per hour Butrans patch.
Okay.
And I feel like that's, yeah, equal to like 0.5 of
That's right.
buprenorphine. And then I would leave her OxyContin totally alone and probably leave her short acting kind of totally alone.
So she's not on any right now. Did you want to start some for her?
Oh, would I start if she's not on any right now? I guess I wouldn't probably start any, but that's now bringing up a good question. But my first inclination would be no. I'm giving her like kind of more opioid, sort of, with the 20 anyway.
And then where did you go from there?
I would wait for at least like I'd wait till day 3, so 48 hours to let the Butrans come up. And then I am anticipating she's going to need, like she's on a high dose. So we need to get to like that sort of 8 to 12 milligrams. So I think I'm feeling conservative. So I start 1 milligram sublingual buprenorphine.
Okay.
And that's going to be 1 milligram total.
Yep.
And then I still would probably leave her oxy alone.
Okay.
And then do you want to keep going?
Yeah. Why don't you just take it through, or anyone else can jump in too if you had something different.
I do 1 BID, and now we're at 2. Leave the oxy alone.
Okay.
Maybe 1 TID, then we go to 3, and that leave the oxy alone. Then 2 BID. It's 4. Now I think I go to 2 TID to get to 6. And then maybe I would do 4 BID, and that would get us to 8. And then I guess we sort of said to try to get to 12 for these higher dose folks. So maybe I would then go ahead and do 4 TID. And then I guess I haven't tapered her at all on her OxyContin yet. So maybe at this point I would start, maybe I would have started tapering earlier. Now I'm not sure how, if I would just stop it. In my brain, I'm thinking, well, I know that the buprenorphine is knocking her OxyContin off of her mu opioid receptor. So I've already tapered her off, even though it looks like I've done nothing. But physiologically, I've tapered her. So I will just say, I would be thinking, okay, like I've done that already physiologically, we can try stopping it. And then I think I would sort of feel tempted maybe now that I'm faced with this, but I start a short acting to like for any breakthrough in this moment. I think I might, I'll say I would leave some breakthrough. And then I would say, well, that might help me understand if I ultimately maybe need to go to like 16 milligrams if they're using a lot of breakthrough. And then I would sort of make that adjustment and like see if we can sort of come off all short acting.
Great. If throw something out, you might start for short acting.
Oh gosh, she's on 80 TDT, so maybe something like 15 of oxy.
Great. Okay. Great. Thank you. Does anyone have anything different or anything to ask Grant about with his proposed regimen? Okay. So I think that looks great, actually. Whoops. This is, I'm stuck. Great. So it's very similar to something that I had come up with as well. So Butrans, I started just like you, and then went up very slowly, 1, 2, 3, 4, 6, 8, 12. You know, as you were saying, she is kind of physiologically titrating down the oxy. If you wanted to come down a little sooner from TID to BID, I might try that at the 6. And then I agree with you. I would have prescribed her some short-acting full agonist opioid at some point just to help smooth out the process, like fill in any bumps as we come off the oxy extended release. And I would have stopped at 12, just as you would. This is actually a paper from Annals where they had 6 patients that were in a pain clinic, so patients without OUD. This is one of their example protocols. It's kind of complicated, all marked up, but this person is someone who started on extended release oxycodone 3 times a day with no short acting. And so you could see they started with 0.5 milligrams sublingual and they did it 2 times a day. The thought behind that is that if you separate the doses far enough from each other, then the first dose would have reached steady state and had a couple hours before you added the second dose. So a little bit less jarring. And then they went from that to 1 milligram 2 times a day and then 1 milligram 3 times a day. So their total daily dose went, 1, 2, 3, 6, 12. So a lot faster than you proposed, Grant. And again, that's where I'm saying like some of this is dependent on this patient and on your comfort as a clinician. And I tend to go slower, just as you did. And you can see here, so the first thing we looked at was the starting dose. The second thing that we look at is what to do with the full agonist opioid. So they kept the TID, and then here, when the patient was at 6 milligrams, they came down to 80 milligrams BID. You don't have to do this. You could just keep it going TID as you said, as you did, Grant, and then just stop it. And they stopped it. They just went, hard stop at 12 milligrams for this patient. Comes off all of their opioids. This person's not on any short actings on top of this. So there are a lot of different ways to do this. What happens to the Butrans patch? That's great. So the Butrans patch, you just take it off after 7 days and don't replace it. So sometimes I will prescribe patients with, like a full month. I'll give them 4 patches of the Butrans when we're starting this low dose initiation, just because I don't know how long or how prolonged the process will be. And I don't want, if they wanted to stay at the patch for longer than 1 week or for longer than 2 days, for longer than a week, then I want them to be sure that they have enough. But you can take it off and not replace it. You could actually take it off. Some protocols have you taking it off, somewhere in the middle, but I feel like you paid for it, so you might as well just get your money's worth and get 7 days out of it. Okay. I am aware of the time. And so I think next time we'll focus primarily on going through these cases, but hopefully this was kind of a deeper dive and a slower pace and working through this one together.